and giving you some of my time. And so just a little bit about me before we dive in here. I am currently the managing psychologist for integrated behavioral health for Peace Health's Oregon network, and that includes 10 primary cares in Eugene, Springfield, Florence, and Cottage Grove. And I've really focused my career on being a clinician, leader, and trainer of primary care behavioral health, and this has included pediatric settings. Currently, I have 5 behavioral health clinicians in the three of my pediatric clinics, and I myself have done clinical work in one of those clinics. So it's one of the reasons I think I was asked to come here today to talk to you guys about PCBH and pediatrics. And so whenever I'm thinking about this question, like what is our role as a BHC, my mind always goes to, like, given the training and the experience that we have, there are so many opportunities for a BHC to have a positive impact on patients and on the medical team. So it can feel very, I think, overwhelming to think about, like, what am I supposed to be doing here? But we get some guidance by certain factors. And so, one of those is, what model of integrated behavioral health are we doing? Another big factor is capacity. So we don't have infinite capacity, even though there may be infinite need or infinite opportunities for us to have an impact on those people. And then also, what are the goals that the clinic has? Why did they bring in a behavioral health clinician, and what are they hoping to achieve? So I think thinking about those 3 things can help kind of hone in on what our focus might be as a BHC. And this is regardless of the setting, if you're in family medicine or in pediatrics. And so in terms of model, I am going to be like zipping through a lot of this information because, as I sort of already alluded to, there's so much that we could be doing. So my goal here is to give you just kind of a taste of the variety of opportunities that there are, and then also provide you with where to go to get some more in-depth information on this stuff. So hopefully you already have some familiarity with the different models of integrated behavioral health. These are the 2 primary evidence-based models that are out there: collaborative care, sometimes also referred to as AIMS model, and then primary care behavioral health. So just kind of the biggest distinction I would say between the 2 is collaborative care is really focusing in on a certain population, so often kind of targeting anxiety, depression, whereas primary care behavioral health is everybody. Right? And so that's what we're going to be talking more about today, because that's the focus of this ECHO as well, as primary care behavioral health. So if you're doing primary care behavioral health, and let me pause for a minute, back up, I think going into a clinic, very important to ask that question: what model of integrated behavioral health are you hoping to do? And if they don't know, kind of having some ideas and thoughts around that. And also being able to speak to what are the distinctions of the model and what value each of them might bring. And so again, if you're going in doing PCBH, like I already said, being a generalist is really important. So if you're going to be able to help the whole population, you need to be able to have some tools for the whole population. And that talks about age range. So obviously in pediatrics clinics, there's the focus on pediatrics. So you're going to be seeing birth till like 18, sometimes often until like 22, 23 before they've moved to a family medicine clinic. But in family medicine, it's all ages. So you also will have opportunity to work with pediatric patients and their families. And so regardless of whether you're in pediatrics or family medicine, it's important to at least have some skills to be able to work with this population. And then the other part that generalist speaks to is, what are the conditions or the concerns that we are going to be addressing? And so we think about behavioral health really isn't a big umbrella term that includes mental health, substance use concerns, and health behaviors. So what are the kind of the things that we need to do, eating well, moving our bodies to keep ourselves healthy? And then, of course, we want to be very team-based, right? So a part of our role is to make sure that we are collaborating with the medical provider and the medical team. Ideally, there's some sort of shared treatment goal and plan that we're working collaboratively together. And in order to do these things, PCBH really emphasizes the importance of physical proximity. So your role also includes going into that site and into that setting and making yourself present and available and accessible. So being there, sitting in on the shared medical pod, so people know you're there, they see you, and then also you can respond to patient needs and clinic needs as well. And then, as I already spoke to, in terms of the skill set that we bring in as behavioral health professionals, we are approaching care in a different way than a lot of our medical colleagues are. So we are hopefully coming at care from a biopsychosocial, functional, contextual approach. And that includes also understanding social determinants of health, adverse childhood experiences, and how trauma in general can impact patients. So usually we're coming at a concern in really trying to understand what are the roots in the soil that are leading to those symptoms that we're seeing here today. And so we can really bring value in educating, again, our patients, our medical colleagues, and the team on these factors that are impacting the issue that we're trying to work through with that patient today. And one of the ways that we do this, really get a good contextual understanding of what's going on with patients, is in the initial visit, always going through the contextual interview. Now, this isn't like a requirement of primary care behavioral health, but a lot of folks that are doing PCBH have really started to adopt the contextual interview as an important piece of the work that we do. So again, doing this interview every initial visit, regardless of the presenting concern, because what we find is if we don't do this, if we go in and we're just symptoms focused and go into problem solving solution mode, that we miss things. And certainly I'll speak to this a little bit more, but a really important role that we have as BHCs is that assessment piece of kind of informing what is the problem here and what is causing the problem. And then from there, being able to create a really good treatment plan. So again, we're kind of bringing in this education that we have, this perspective that we have into all of the things that we do. So those conversations that we're having with the medical team and providers in our notes, so making sure our documentation includes this information and is easily accessible and readable by the other members of the team. And yeah, just in the feedback that we provide from like the warm handoff of closing the loop and talking to our medical colleagues about what's going on with that patient. With that, we not only are bringing our kind of behavioral health knowledge and perspective to medicine, it's also really critical that we incorporate those physical needs, physical functioning into the work that we're doing, so that we're also integrating that into our assessment and the care that we're delivering. And so, you notice in the contextual interview, it has those health behavior questions that it's asking about. How are you eating? How is sleep? Are you moving your bodies? Those kinds of things. Because that is really essential in understanding, again, why is somebody having trouble focusing? Or why is this kid, having these huge tantrums? We need to know these pieces of their lives as well. And so a favorite analogy of mine that I use all the time, both when I'm conceptualizing a patient and then also in the work that I do with a patient, is this four-legged chair. And so what I might say to somebody is, so imagine that you're sitting on this chair, and usually they are sitting on a chair. So I can say, see the chair that you're sitting on right now, and that has 4 legs, right? And one of those legs is nutrition. One is sleep, one is exercise, and one is relaxation, some really good dedicated time to relax and recharge, right? And what I'm hearing from you after asking these questions is that, you're doing a pretty good job of getting a well-balanced diet, you're eating your vegetables, you get a good amount of physical activity during the school breaks, and after school, you're in sports. But sleep is really not where we'd like it to be. So having a hard time falling asleep and staying asleep, so you're not getting the recommended hours of sleep. And so that leaves that leg really shaky, right? And it's hard to stay stable and functional on a chair that you're constantly trying to balance and stay atop, right? And so that to me says, maybe we want to talk first about some sleep strategies before we even get into, potential other things that might be helpful in this situation. So sometimes that's my intervention, that's my psycho ed at the end of the contextual interview. Or, if several legs are shaky, I might say something like, these legs are shaky, which one of these could we start with? And again, this goes for both our little list of littles all the way up to our adult population. We all need these things, right? And then again, we take this information that we just gathered and we are educating our colleague. We're bringing that into our conceptualization and our treatment plan that we offer to them. Okay, so that's kind of touching on how PCBH is going to inform the role that you're taking on in your clinic. And then we want to think about capacity as well, right? So I find that kind of no matter what, there's always more that a behavioral health clinician can be doing. So we have to focus in on, something, do it well, and then start to expand more and more and more what we're doing. So this graph is just sort of representing the range of severity of behavioral health concerns there along the x-axis. So as you go to the right, there are more severe concerns. So we're thinking about, depression, anxiety that's really debilitating, getting in the way of that kid's functioning, keeping them from going to school. Maybe there's some significant suicidal ideation. And so we see that we take the whole population, it's a smaller portion of the population that has that severity of concern. And then we work our way to the left, we're seeing that the potential for behavioral health is expanding. So we're thinking about the fact that everybody could benefit from maybe some prevention work around behavioral health needs and whatnot. And so what often ends up happening is there's sort of a natural prioritization based on capacity for the higher severity needs that are happening, right? So we don't want to say we're only going to see those patients, right? Because we still want to be doing the primary care behavioral model. We still want to be messaging and demonstrating that we can be helpful with a variety of concerns. I just think it's important to be aware that if you are just one BHC, you most likely are going to mostly be seeing anxiety, depression, those higher level severity, with some of the other like behavior stuff kind of sprinkled in there potentially. And that's because this is what happens, right? So this is actually a graph. So you think about everybody that has a mental health issue. So that's the big circle. About half of them receive some kind of treatment, and just over half of those that receive treatment are receiving that treatment in primary care. And this plays out really similarly in adults as it does in pediatrics. So people, if they're getting help, are very likely getting their help from primary care. We also know that people who aren't having their mental health concerns addressed are still showing up in primary care. So there's huge opportunity to meet patients where they are. And that's why we're talking about integrated behavioral health, because we know there's a need there, right? But this slide is more to just emphasize why it makes a lot of sense that as a BHC, a good portion of your work is going to be around those mental health concerns that are showing up. And that's because, right, we have that skill set, we have that training. Yes, medical providers get some of that, but compared to the other training that they're getting, it's very little. So they've had to dedicate their training and their career really on life and death circumstances. So they really have to know pathophysiology and medicine, right? And so that's where their focus has been. And they maybe had like, a 2-hour workshop on motivational interviewing. And, they know that, CBT is a evidence-based treatment for anxiety and depression. But they usually don't know very much about what CBT looks like and how to implement that. Most of their training in terms of mental health intervention is on psychopharmacology, so medications that are going to be helpful. So a lot of times that's the tool that they have, and they utilize that, but they don't have the tools that we all have, having dedicated our training and our careers to behavioral health, mental health concerns. So this is some data just showing that, we know that symptoms of anxiety, symptoms of depression are showing up in our pediatric patients, sometimes as young as 3 years old. This data is actually from 2018, and we knew there was a huge increase in these things with the pandemic. So it's only gotten more so since then. And let's see. So all your clinics, so pediatric clinics, family medicine clinics, usually have standardized screeners that they're doing. Most of the time, there is a requirement to actually screen for depression. So you'll see that the PHQ is being implemented on an annual basis. And then in pediatrics, there's always some sort of developmental screener that is happening. So these kids are coming in for their regular well visits, and one of the pediatrician's job is to make sure that they're developing kind of appropriately and in a healthy way, and that includes their socio-emotional development. So as a BHC, you really want to know what are the screeners and how you can utilize them to identify patients that could potentially benefit from your services. And then you might also want to think about, are there additional screeners that might be helpful for us to have? So there's been much more discussion and even recommendation around also screening for anxiety and not just depression. So you might see that as well. Now, the generalized screeners, like I said, are going to capture some of that social-emotional development, and that often also includes some questions about, actual mental health symptoms. So again, knowing what the screeners are, what they're asking about, and how you can utilize them to identify patients. And then with these mental health concerns, like we've already talked about, you're going to get in there, do your initial assessment, and be able to use that information to help inform that treatment plan. And then very likely also be offering some intervention services. Ideally in that first visit, you have something that you're offering them, and then likely we'll be having at least a couple follow-up visits with these mental health issues. A great resource for interventions in these areas is the Seattle Children's website. So I have that for you guys. And they have modules for all of those topics that are listed there. And the modules include like video instruction for you, for the clinician. It includes workbooks for both you and the patient, and some handouts and stuff as well. So really, really awesome resource. And I've even looked at it, and it's helped kind of inform some of my work with adult patients, particularly in the trauma area, because again, this is all evidence-based stuff that they've adapted to primary care settings. The other piece of the PCP collaboration, the way that we can be helpful for these mental health concerns, is if they've decided to start a medication and we're following that patient, it can be really helpful to ask the patient about how that medication is going. And so just checking in with them, like, are you taking it? What changes, if any, have you noticed, both positive and negative? And then also helping to ask those questions when they raise a concern. Like, I think my medication isn't working, or I'm thinking about stopping it because now I feel worse. Asking some questions around that, because I find that especially in pediatric populations, there can be this reactivity where they're like, oh, it's not working, so I'm going to just stop taking it. And then the story can be that that medication didn't work for me. But when you do a little bit more digging, you learn that there's likely a very different cause for the worsening of symptoms. So maybe something happened in their life that would have intensified those feelings, or you learn that they didn't take the medication consistently long enough to actually be effective. So that can be hugely helpful. Whereas, sometimes the PCP will say, okay, let's just change the medication. Then everybody's frustrated because we've gone through 3 medications and none of them are working, right? Okay. And then with suicide risk assessment, I think it's really important as a BHC in family medicine or in pediatrics to have a clear process for when and how suicidal ideation is going to be assessed, and then what is the response going to be. Now, I would definitely caution against saying the BHC will just do all of that. I think we also definitely want to be upskilling our team members, the medical colleagues, and the whole team on how to talk about suicide and how to assess safety and do a safety plan for a variety of reasons. One is to have that environment where that's an okay thing to talk about. That's something that we want our patients to talk about. And then we want everybody to feel at least capable of being able to have that conversation, because this can understandably bring up a lot of uncomfortable feelings and sometimes some knee-jerk reactions when it comes up. So we want to help our team have some skills around these conversations, and then again, having a clear process for when to screen, how to screen, and what the response plan is going to be. So along with the screening piece of it, so obviously sometimes it'll be captured with the PHQ, but a lot of clinics actually just do the PHQ too. And if that's not endorsed, they're not going to get to that suicide question. And we know that thoughts of suicide can certainly come up in the absence of those 2 depression core symptoms, right? So you don't need to have that to sometimes have thoughts of suicide. So some organizations have decided they're going to ask the question around thoughts of suicide, and there's some screeners that are just focused on that as well. So another thing to just think about and talk to the team about. Okay, other big conditions in pediatrics is ADHD and autism. And again, we as BHCs can have an important role in both the diagnosis or the diagnostic process and then intervention or treatment of those conditions. So ADHD, there's a heavy reliance in primary care on using screeners, so the Vanderbilt screeners. And you do see that can be a kind of a quick jump to diagnosis when the screeners are positive. So I think we have a very valuable role in, again, going in and doing that initial interview, getting more contextual and historical information that helps us to understand those symptoms that might look like ADHD and what else might be contributing to those symptoms or causing them completely. So going and doing that piece to at least inform what other diagnoses there might be here, and then providing just education around screeners, aren't diagnostic tools. And then certainly an important role that we can have in treating or intervening on ADHD. So the standard guideline recommendation from the American Academy of Pediatrics is that for 4 to 5-year-olds who have the diagnosis of ADHD, that they start with behavior strategies. So start with those, don't start with medication. And then once they're 6, you can do, the recommendation is behavior modification and medication. So, again, making sure or helping your clinic to be able to do that, to follow those guidelines, and you yourself having some tools around supporting those patients who have ADHD. So behavior strategies, looking at things like time management, organizational skills, emotional regulation, and then school support. This is one of the ones that kind of goes back to my comment about what are the clinic's goals. So some pediatric clinics really have their BHCs doing a lot of the liaison work with the schools. So providing like, recommendations for IEP or 504 plans, and doing follow-up to hear how things are going at school, adjusting that. So a lot of kind of phone calls and conversations with teachers and school staff and whatnot. And just knowing that then is going to take away from the direct care that you're providing that patient. So my preference and tendency is to really have some strong boundaries around how much work is going to be done on the phone. But I think talking to the whole team and kind of coming to that decision together can be helpful, because it does work well for some settings to have the BHC take on that piece as well. With autism, ideally, the kid has been coming to their early life well visits, and the potential signs of autism are being captured through those developmental screeners. And so again, the ideal situation is it's caught in that screener, then usually that triggers another screener, the MCHAT, that's specific to autism. And then if that is positive for autism, then for potential autism, then they have to go to a specialty organization usually to do to get the official diagnosis. A lot of communities, those organizations that actually do the autism diagnosing, are inundated. So the wait can be like a year out, which is really unfortunate when we know how important early intervention can be. So some clinics are coming up with strategies for the BHC to assist with that diagnostic process. So really partnering with that outside organization that's doing those diagnoses, and saying, is there a piece of this that I can do here in my clinic? And if either in terms of helping assist with that diagnosis, so doing some of the questionnaires, doing some of the activities with that patient, so that then the other organization can really do the specialty piece of it, which can greatly then reduce, obviously, the wait that they'll be, because they're not having to spend as much time with the patient. The other thing that I've done in my settings is to at least there's a follow-up version to the MCHAT. So it's a little bit more in-depth information we get that can help to rule out patients who do not have autism and don't need that specialty evaluation. The other tricky thing is that both ADHD and autism has been coming up a lot in our older kids. So 10, 11, 12, 17, 18-year-olds, it comes up with adults too, now wondering if they have ADHD or autism. Unfortunately, for autism, there's not a great screener for older kids. They are out there. So just being prepared to kind of have those conversations around neurodivergency, knowing where in your community, who in your community can do those evaluations with that age group, is really helpful and important. And then also knowing that, like, regardless of whether or not we have a diagnosis, us as BHCs have the skill set to at least assist with some of the behavioral skills or strategies that might be helpful. So still going back to that functional approach of like, what's getting in the way of your functioning, what are your goals, and how can I help you achieve those goals with the skills that I do have. So that might be with the younger kids, working with parents on parenting strategies. So your basic standard parenting strategies are still helpful with these kids, and emotional regulation, all those things that I already touched on. Okay. So we've talked about kind of the mental health and what might be showing up in pediatric settings. And then as we kind of expand out away from towards the lesser severity, we're thinking about parenting and other behavioral needs that happen. So parenting is going to be a big one, because this is what every parent and kid needs, right? These are challenges that almost everybody goes through. Once a baby is born, the parents don't all of a sudden have all the knowledge and tools to be able to respond to all the challenges that come up. So having at least a basic foundational skills around responding to big feelings and big behaviors or challenging behaviors. So, what to do when those tantrums are coming out, because they're going to also understand that psycho ed for parents about kind of what's happening with that dysregulation that's going on. Facilitating healthy social development and functioning. So how do we help our kids to follow the rules and have routines and navigate transitions, and being responsible. So learning how to take care of themselves and contribute to the household. Um, and those things all kind of fit within, like, when parents talk about kids being non-compliant or they're so defiant, or all those kind of things. So trying to put also a positive sort of spin on what's going on with that stuff. Potty training. So, pediatricians are doing a lot of this stuff, kind of the basics, and definitely with potty training of like talking to parents about kind of the options that they have and some of the basic recommendations for helping to support a kid learn how to use the potty. And then it can be really helpful to, when there are kind of additional challenges that are coming up, to be able to bring a BHC in to talk about what's going on, and to come up with a plan that's really catered to that particular patient and that family, and being able to kind of follow up, say how it's going, and make modifications as needed. Seattle Children's, the FAST program, has, like I said, some modules on behavior and parenting as well. So check those out. AAP, American Academy of Pediatrics, has their healthychildren.org that also has some good resources and information for these things. Okay, and then health behaviors, sleep. Sleep can come up a lot for all ages. So as a BHC, you're going to want to at least know where to look to find the sleep needs for each age group. I will say I don't have them all memorized, and kind of my knowledge ebbs and flows depending on the population I'm working with. But it's always a quick Google search or up-to-date search away to get a nice little table. There's often, even in the patient education section of your electronic health record, will often have this information. So knowing, like, when you're asking that sleep question, knowing whether or not that's in the range of what is recommended for that age group is important. So then you can, add that into your conceptualization of what's going on, and also your recommendations for them. And then common sleep challenges. So sleeping independently for kids of all ages can be really hard. And this includes our infant sleep training. So that's a hurdle that a lot of parents and babies have to go through, is learning how to initially, at the first moment of life, learn how to sleep on their own. And this is also another topic where there's like an overwhelming amount of information on the internet. And there's a variety of strategies. Do we do cry out? Do we do Ferber? And yeah, it just can become very overwhelming for parents. So again, being able to go in and come talk through those options, and then come up with a plan that's going to work for them in their home, in their family, and the values that they have, and offering follow-up if things aren't working well. I've found that can provide a lot of relief to parents, especially thinking about very sleep deprived parents, of having some clear, here's what you can do. And then I have some pediatricians that are just like, they're like, oh, I'm going to send my BHC in, so they can spend that time with you right now, which is awesome. And then with our older kiddos, just having similar difficulties, but at a later stage of life, of being able to fall and stay asleep on their own. Poor sleep hygiene, especially around screens. So always asking about how screens are maybe impacting sleep, or questions that will get you that information, and being able to talk to your patients about sleep strategies, sleep hygiene, and then understanding if anxiety or even depression is maybe impacting the sleep. And then also health behavior, we can be helpful with healthy eating when there's maybe some improvements that could help with healthy eating or physical activity. I didn't call out eating disorders in this presentation, but that is also something that is showing up a lot in pediatrics. And so knowing to ask questions around, again, it's in the contextual interview. So how much are you eating? How often are you eating? And often with adolescents, I'm asking the questions about, how do you feel about your body, or do you have any stress or concerns around what you eat, how much you eat, those kinds of things to get a sense of that. So we can be helpful in intervening on any health behaviors that are not being supportive of their health. And then we can also be really helpful in establishing good, healthy habits at the beginning. So thinking about prevention, right? This is what like my ultimate dream is to have such a robust PCBH model in pediatrics and in family medicine where we can actually do some really powerful preventative work. So again, big piece of pediatrics is it's anticipatory guidance. So at every well visit, they're talking about what the next kind of phase or the next challenges might be. They're checking in on things about like, are you wearing your seatbelts and your helmets and that kind of safety stuff. So just imagine if we could have a behavioral health well visit that every once a year in your life, we're going to talk about these things. We're going to talk about how anxiety and sadness is going to show up in your life and what to do about it, not to be so scared when it does show up. There are a couple of states that have actually approved this, so this is potentially something that might happen. And even in the absence of like it being kind of a mandated thing, just thinking about as a BHC, what could you do at each one of those well visits to help support that patient? One of the ways to maybe focus that is around the healthy eating and health behaviors. There's a really nice way to easily kind of conceptualize the recommendations for these things, and that's the 5210 from Maine Health. And so a recommendation is 5 or more fruits or vegetables, 2 hours or less of screens, 1 hour of physical activity, and 0 sugary drinks. So I think that's a nice way to kind of distill down, again, all of the recommendations that are out there and guidance that's out there into these 5 things or 4 things. And then what Maine Health has actually done, and we're starting to put together a process for it in my pediatric clinics, is to actually have the BHC go in at the well visit and to go over the 5210 questionnaire and to partner with the patient and their family on coming up with a goal in one of those areas if the family is wanting to do something like that. And that's regardless of health outcomes. So this is really being preventative. Let's establish good, healthy habits early on in life. The other thing that I actually put in the prevention section here is adverse childhood experiences. And one of the ways that this can take on a preventative nature is understanding how maybe a parent's ACEs is going to affect the parent that they are now. And providing that education to the parent in that, and having that understanding, that compassion for when their baby cries, and that can be very triggering for them, and what they can do to help with their own emotional regulation and recognition of those things. So this is just an infographic that I think is neat, kind of just thinking about all the different opportunities for intervening on ACEs and supporting healthy communities. Okay, so that was a whirlwind of information. And I wanted to pause here and see what kind of questions or discussion points that there might be from you all. Okay, Norma has a question. Feel free to come off mute.
Hello.
If that works for you.
Yes,
Hi.
thank you. So yay, this is very timely, and thank you so much for your presentation. It was very clear and helpful. A question that has been coming up for me and one of my providers is with the MChat. And so when you mentioned it, I wanted to ask you how, like, what do your warm handoffs look like with MCHAT, with, I guess you mentioned the follow-up, and I actually, while you're talking, I went ahead and printed it out. I was like looking at it.
Yeah.
And I'm just wondering, because, you know, there's still so little, because I think it's like 15 to 30 months for MCHAT. And so I was like, what do you do? Because that would be, because right, for me, I'm like, well, okay, we could talk about like parenting. We'd still have to wait for another eval, but what can I actually do with that? So when you brought it up, I was like, oh, I'm gonna ask.
Yeah. Awesome. Yeah, so I would say do the follow-up, because I think that can be really informative, because sometimes the questions were answered, but when you dig a little bit more into the details, which the follow-up guides you to do that, that can sometimes help clarify whether or not that specialty evaluation is even needed, or how severe are we talking about. So do that, and the format of it is excellent. It really kind of walks you through the steps. And what I actually did, because I was doing this enough in my setting, is I laminated the questions, so that I wasn't having a new form every time. And then what I do is you just take the questions that they marked as, the MCHAT says is as a fail. So they marked as a potential symptom of autism, right? So you just take those questions out, and you're only needing to follow up on the ones that pinged positive. So that helps to streamline it. And then, yeah, I would say, you know, I'm usually relying back on some of the standard parenting strategies. So obviously, you know, you want to take into account what's the verbal ability of the kiddo, those kinds of things. So, you know, you might be adjusting what you say based on that, but you want to kind of do that with every kid. Anyways, but, you know, talking a lot about emotional regulation and positive one-on-one time, you know, really starting with that foundational stuff. And messaging like this stuff is going to be helpful while we're working on getting you set up for success. There's also in some communities, there's organizations that can start to provide some support even before a diagnosis. So sometimes, as long as it's clear enough that there's some form of like impairment, developmental impairment or challenges, they might be able to access some resources. So knowing who that is in your community too, and seeing if some of your patients can get access to that before having that formal diagnosis can be helpful.
Yay, great. Thank you so much.
Yeah. And then Rebecca had a question about how many BHCs do you have or recommend per patient in the practice? Thank you for bringing this up. I meant to go a little bit more into detail in that. So what I am learning in my own practice, as well as from just, you know, continuing to interface with colleagues across the country who are doing this work, 1 to 4 really seems like minimal. So what I mean by that is 1 BHC FTE for every 4 medical provider FTE. That's the way I look at it versus patient panel. Now, there are things to think about, like what is the complexity of the patients you're seeing? Sometimes thinking about the payer mix, and then just also the complexity. So obviously higher complexity, higher intensity of concerns, the more BHC you're going to want. But a rough kind of 1 to 4 is a good thing a good start, I would say. And then knowing that, you know, the more you have, if you get 1 to 4 in there and you are finding that your BHCs are seeing patients, they're rocking and rolling, you know, seeing at least like 8 in a day, that's going to vary too. So really kind of looking at it, have you gotten to a place where you're financially sustainable, and you're starting to notice patients are having to be scheduled further out, even though like warm handoffs are being utilized. So if you have highly productive BHCs, and you're still not meeting the needs, then that's indication that you could use more BHC. But 1 to 4 to start. Any other questions, things I can go into in more detail?
I have a question. So I'm a postdoc in a primary care clinic, and so I do the PCBH side, but I also do therapy side. And I guess I'm wondering as I'm like looking for jobs and how common that is that the PCBH side does the two, both the treatment, sort of long-term outpatient psychotherapy or well, short-term psychotherapy treatment and also the PCBH, or do you find that people are usually sort of only in the PCBH side? Does that make sense?
Yeah, I think so. So let me answer and then you can let me know if I didn't answer it. I think what works best is for you to do one thing. So to be a PCBH clinician and doing
Okay.
PCBH. That being said, I think PCBH allows for a flexibility. It's supposed to, right? Because primary care is flexible. So we can't have these rigid rules around you only can have 5 visits with a patient, right? That won't work well. Although again, a good question to ask the organization is, are you going to have limits on the number of visits I can have per episode of care, right? But ideally, there is no limit. And so you'll find that about like 10% of your patients, you'll see ongoing. You might have 10 visits with for that episode of care for whatever reason. It's clinically indicated and they're getting value out of it. So you've continued to work with them. Again, there's going to be a variety in what other resources there are in the community. So if you have access to, outpatient mental health that patients get in, you might be referring more often and keeping patients not as long. But most of the time, there's pretty limited access. So you're seeing some. And I think it can work really well to have a practice organization that has both. It just has different people doing them. So you have the BHC doing PCBH really in the clinic, doing that side by side, doing that same day access stuff with the medical team. And then you have a co-located mental health therapist that has an office that's scheduling visits, that's seeing patients longitudinally. We have that at Peace Health. I mean, Peace Health has a lot of behavioral health, mental health services, and it includes a couple of the clinics have a co-located therapist actually right there.
Awesome.
And that can work well.
That is very helpful. Thank you.
Yeah. And I guess I'll say, don't think that just because you're going to be doing PCBH that you're not going to be doing longitudinal care. That's the other piece, especially if you're in family medicine. You could see that patient for their whole life if you're there that long, right? It's super cool. It just tends to be like episodic care. So you see them, they're struggling teenager, and then 5 years later, you see them as a new parent, kind of thing.
Yeah, that's true. That's okay. Yeah. Thank you for that reframe. Yeah. Thank you.
Yeah, absolutely. Other questions. The other thing is I do have some case examples if people were planning to hang out for a little bit longer. But Alina, I wasn't totally clear on the time. When do we want to actually be done at, or is it?
Okay, so the time is now 12:53. So people usually start to leave in the next 7 minutes, but we can stay past 1 o'clock. This meeting is booked until 1:30 CST time. So whoever wants to stay back, we're more than welcome to, but people usually start leaving in like a bit.
Okay. We'll let them, so feel free to leave if you've gotten what you needed. I'll maybe run through at least a case example, and then do chime in with any questions that do come up as well, because I can pause the case example to do that. Okay, so let's see, I had multiple here. So this one, 13-year-old female who presented with anxiety and actually started out in the primary care clinic or in the pediatric clinic as frequent migraines. And then what would happen is she'd get these migraines and then she would go to this worst case scenario, right? Like I have a brain tumor, something's really wrong with me. And so appropriately, the pediatrician brought me in and we ended up having 3 visits just once a month. And so I sort of broke down what were the things that I did in each of the visit. So as is common in my first visit, after doing the contextual interview, my common psycho ed is around understanding the role that emotions play and how they're not just bad things. They're actually very useful tools, and also understanding though how they can have that negative impact on ourselves. So making that connection that is made in CBT and ACT. And so with her, what I wanted her to do is just start to pay attention, right? Just start to notice when your mind is doing that what if, worst case scenarios, or worried about judgment from others. She also had a lot of social anxiety. And just take notes. And this is a common intervention that I'll give, particularly if I think, I'll be seeing the patient back again, so we can talk about that experience. But again, it's just that awareness piece in ACT of like noticing, paying attention, noticing these connections, and the process. And then in the second visit, we dug a little bit more into how emotions, how feelings are actually good things. So that acceptance piece of ACT. So anxiety is really important and helpful. It alerts us to potential threats, the things that are important to us. And so pausing when we feel anxious to consider, how is anxiety trying to help me right now? And then using that energy to do what's important to you. A common example that I'll give is around like testing anxiety. So, the exam itself is not dangerous. So it's not alerting us to a physical threat, but that test is important to you. And so if we actually say, oh my gosh, like, my brain's giving me the energy to really take on this test, and actually can help me to focus on that text. That reduces the anxiety that we then feel about anxiety. And then we built off that to do a little bit of thought challenging. So this is how sometimes I'll go back and forth between ACT and CBT, just considering the patient, and doing that, kind of considering how likely is it that what if is going to occur, based on the past evidence and experiences. And so at that third visit, she really came in, I don't know, I did that. Feeling like she was doing a lot better. Sure, I think by the second visit, the migraines were a lot less frequent, and she was starting to have an understanding of the role that stress and anxiety was playing in her life. And what she said at the third visit was like, I think I'm good. I think I have some good tools to really navigate this. And what was most helpful is that in our very first visit, you helped me realize that I'm okay. So that piece of like, there's nothing really wrong with me, that this is part of being human, that can be a really powerful intervention. And then question, Norma, around emailing. You can email me, yeah. If Alina, do you provide my email address to everybody? Or you can, I can put it on the slides that I'm going to send you. Maybe that would be the easiest.
Yeah.
Okay, questions about that case? Okay. Yeah, so 3 visits once a month. She really got what she needed and was feeling emotionally and physically better after that. This was my little 6-year-old who came in having some really big feelings, had dealt with a lot of big changes, dealing with the pandemic and have a new baby sibling, and going into grade school. And so these feelings were getting really overwhelming to the point that she was hitting herself. And I often describe that as like the emotions are so intense, they're just trying to figure out any way to get them out of their body because it's so uncomfortable. And so we talked about what the parents can do. That can be a very distressing experience for a parent, right? To see their kid themselves really distressed to the point that they're hurting themselves. And so taking this stance of really being present and calm themselves. So validating, I see that you're upset. and staying calm and just sitting with her while she kind of rides out those feelings. Sometimes we can do some protective measures too, like a gentle hold. That one, if they're really not hurting themselves with the hitting, I say just be present and let them ride it out. If they're hitting their head, against a wall or a table, putting your hand there or a pillow there so that we're not restraining them, because that can actually intensify the fight or flight. But we're still protecting them by not letting them hit themselves against something hard that might be damaging. So that was really the focus on that one. Is we're to work on just regulation skills, parents regulating themselves, and through that co-regulating with their kiddo. And then 4 months later, she wanted to see her feelings doctor again, which I thought was pretty cool. And she was doing a whole lot better. She wasn't hitting herself. They were practicing these regulation skills. But she wanted to understand why she still got angry sometimes. So I think this was an awesome example of that sort of prevention work that we can do in establishing like a healthy relationship with our feelings, and for people to know that they have a space and a place to go to talk about these things. And so she wanted to come and learn more about her feelings. And so talked a little bit about ACT. So paying attention to what is the anger teaching her? What is it showing up? When is it showing up? And what are the thoughts that are going along with it? And likely it's telling you something about what's important to you or your values. And so again, we can notice those big feelings. We can sit with them. And then when they come down, we can decide how to respond to them. So again, little 6-year-old that I was doing some of this with. And then about a month later, the parents wanted to be seen because mom had just completed cancer treatment. And so this girl was having lots of questions around it, and they were wanting some guidance on how to talk to her about this. And so this example I liked, again, because of the prevention side of things, the developing a healthy understanding of emotions, but also that there was this variety. So now that they knew that they had a BHC that they could go to, they were doing that, right? And so I'll often say, going in and introducing yourself to a patient so they know you're part of their team can be a really helpful strategy to have as well. And then just in terms of like what I did in that last visit, in general, when there's significant, health concerns, really big things going on, it's important to still provide kids with information, keep it simple, make sure it's accurate. So don't say things like it's going to be okay if you don't know that. And then also saying something like, oh, don't worry about it, it's going to be okay. What does that do to our anxiety? We just don't know. Like, it's not very reassuring, right? Because it's not giving any specific information. So having them say something like, well, I completed, my treatment. I'm going to have to go into a follow-up. They're going to be keeping a really close eye on the cancer to make sure that it's not coming back. And in the meantime, I can, go back to being mom and doing all those things. Okay. So I got a question in the chat. What would warrant shorter follow-up visit? 2-week follow-up versus 1 month? Is 1 month the recommended amount for young children? I would say in pediatrics, let's see. I would say in adolescents and teens, when we are working on mental health stuff, so anxiety, depression, usually I'm doing my first 3 visits a little closer together, not necessarily 1 week apart, but I find to get some movement and some traction, it can be helpful to have the first couple 2-3 visits closer together, so 1 to 2 weeks. I would say what in my mind is more of a 1 week, that's the high risk situation. So that's kind of a for sure. So if there's, suicidal ideation, and we, were able to do a safety plan, and they agreed to keep, follow the safety plan for a week, wanting to see them back in a week. I think the longer ones, and this is a decision that you want to make collaboratively with your patients and their family member who might be bringing them in, but kind of thinking about and asking them the question, like, how much time do you think you need to practice these things, and give it enough time to see if it's actually going to work, if it's actually going to be helpful. And so that's a piece of this too, is saying we need to give enough time to make it work. So if I'm doing like a sleep plan, I'm going to give it probably 2 weeks. And I'm going to say something like, we want to really follow this sleep plan really closely for 2 weeks. And sometimes I'm saying, if at that point it's not getting any better, then call and make another appointment. Or if they really want to go ahead and schedule that 2-week appointment, we can do that. Similarly, for any like behavior change stuff. So if we're starting a reward system, or we're working on potty training, we're working on even emotional regulation with the littles, giving it at least 2 weeks to give it enough time. And then I think in terms of longer follow-up, it's the parents that are like, yeah, we got this. We feel confident that we can really do this and keep it up for a month. So let's just check in. So there's kind of a lot of factors that go into that, but hopefully that helps give you kind of a sense of what to be thinking about in terms of when to follow up with the patient. Other questions? Do we still have people? We still have people. Okay. Cool. Glad that was helpful, Bianca. Okay, I think I just had one more, so I can run through that. And again, love that you're putting some questions in the chat as they come up. Okay. So 12-year-old with school avoidance, this is a big thing in pediatrics. So having a lot of anxiety, not going to school. I've found that it's gotten more intense after the pandemic. So that really re-entry into the school setting was really hard for a lot of kids. And I'm seeing kids who haven't gone to school for over a year. It's kind of wild. So this was a warm handoff. So she came to the pediatrician because this was going on, but she's also feeling really sick before school. So this is a common presentation of having a lot of tummy trouble before school, and then not going to school because of it. So especially at the beginning of the school year, you see kind of an uptick in this. So great thing to share with your medical colleagues, your pediatricians, on, hey, if you're noticing this, it's probably a good idea to bring me in, because it could be anxiety that's going on. So that's what was happening with this girl. And she was going in late to school, or being picked up from school on most days. And they tried a modified schedule. A lot of schools are willing to be flexible and work with families. So she tried going to just half a day with no improvement. And so mom was at the point they really tried, and she was wondering about a medication. So what I did is explained kind of what's happening here, right? Like, she's thinking about going to school, the anxiety's coming up, the tummy trouble's coming up. So she's also worried about getting physically sick at school. And they said, well, let's not go to school. Whew, that's a huge relief. So I'm not feeling anxious anymore. But then it comes up again the next day, right? And the next day. And what we see is that each time the level of anxiety isn't coming down to baseline. Right? It's continuing to go up and up and up. And so this is classic behaviorism, foundational stuff around CBT and ACT and the cycle of anxiety. And then we also can see with patients of starting to get some depression symptoms in there with why can't I just do this? Why can't I just go to school? There's something really wrong with me. And that can add to this vicious cycle. And so, what's happening is the brain is thinking, my anxiety is just going to keep going up and up and up and up. until something really bad happens, like my brain explodes. Like usually we're not articulating that, but that's kind of the feeling that we're having, right? And so then it makes sense that the brain is like, let's just not do that thing that might make our head explode. So we avoid. But instead, what we know is that if we push through that anxiety, we go to school and we stick out the whole day, that eventually the anxiety is going to come down. Now, it might not come down until we get home from school that afternoon, but even doing that has shown us that our head didn't explode. So what we want to do is push through that anxiety, not avoid because of the anxiety. And there's an image of, you know, how I'd drawn this out on the exam room paper. I find it helpful to have that visual. And this is something I was walking through this with the patient and with the parent. Very important to have the parent present as well, so they're understanding this and can help support the kid. So we see each day the anxiety should come down, get better and better and more manageable. Okay. So they decided that after this, they're like, well, let's try this. Let's go to school and hold off on taking a medication. Let's see if we can push through the anxiety enough. The other piece that I'll also really emphasize with parents in this situation is how important it is that they stick with this plan, that they can be empathetic and compassionate. Like, I know this is really uncomfortable. This feels really scary. And we're still going to go to school, right? Because I know that you can do it, that you can handle this level of anxiety. So they need to be the messengers of confidence, and also, you know, confidence in their kid too, that their kid can handle this. So this is an example of my note. So at the top of my note, there's always the assessment and plan, or what I've titled more explicitly, recommendation to BCP and the medical team. And so what I said was anxiety at school following lockdown exacerbated by having panic symptoms at school resulting in current fear and panic. My recommendation is to balance validating how uncomfortable and scary this is while empowering patient to learn how to push through these feelings, symptoms, acknowledging that they themselves are not life-threatening. So this is where that context, that, okay, she had a lockdown that exacerbated it. So having that context is important. And then having those recommendations clear and explicit. And then the patient instructions, that's what I printed off. And so these are like, you know, the first one on panic attacks, not being dangerous, and to write them out. That's a dot phrase that I have that I just populate into my after visit summary and can print out to patients and give to them. So that was the plan that they were going to try. And they were going to follow up in 2 weeks if they needed it. So this was a scenario. I said mom felt confident that they would be able to execute this plan, and they're like, we'll check in with you if we need to. What happened is she called 2 weeks later, which was awesome, and she said there'd been significant improvement. The girl was going to school, and they didn't need to follow up anymore. So one visit got the kid going back to school and understanding the role that anxiety was having in her life and her physical symptoms. Okay. That is all I have. Any final questions? Like I said, I'll be sending, or Alina will be distributing a PDF of the slides, and I'll have my email if you have any questions. I imagine you all are not in Oregon, but just so you know, I do have multiple positions for master's level behavioral health clinicians in family medicine. I have filled my pediatric clinics currently, but if you're interested in family medicine and living in the Oregon area, let me know. Okay.
Thank you so much, Dr. Wahlberg. And just so you all know, as usual, I'll be the one sending out a follow-up email, and it'll include Dr. Wahlberg's slides, the recording of the presentation, and then I'm going to CC you, Dr. Wahlberg, in that email just so that people have easier access if they need to reach you. But please just remember to fill out the evaluation survey. That's the only way to get your certificate of attendance to get CEU credit for this session. But that's it. Thank you all so much for joining, and we hope to see you again next time around. Have a great day.
Thank you, Dr. Wahlberg. This session was
Yeah,
great.
thanks guys for hosting and hanging in there for a little extra time. Cool. All right, bye.
Bye.